to pay.
Expert panels with advanced degrees are sure to satisfy your curiosity.
Did we mention it's free?
And if you think you'll find a better time than this, then come on down and test your hypothesis. Cause you're gonna learn a lot if you wanna stay down at the Science Cafe.
Good evening and welcome to Science Cafe. My name is Dan Marchek. I'm one of the founders of Science Cafe. I'm going to do a little introduction of the panel, but I don't really know much about them, so I'm going to let them flesh it out. And I will start with Theresa. Theresa Calope is a registered nurse. Did I get that right?
Yes, sir.
Okay. Is a registered nurse with the City of Nashua Health Department. She's been working with the public health for the past 9 years. She started her career in public health as a grant-funded nurse, working with lead and TB cases. She moved on to working as a program vaccine manager and coordinator, fulfilling grant-related requirements. She passionately enjoys working for the City of Nashua and the community. That's nice. It's nice to hear people say that. She diligently continues to educate the importance of vaccines in our community, as well as promoting the need for prevention against disease. Theresa. Now, the two doctors here didn't send me anything, so I was forced to use Google. And I don't know if they know what Google says about them.
I don't speak Portuguese. That's kind of that.
So Dr. Colleen Guiry went to medical school at Mount Sinai School of Medicine in New York. She did her residency as Madigan Army Medical Center in Tacoma, Washington, and she's board certified in family medicine. Now, interestingly, they give you quotes on their website from patients.
I can't wait.
This is too much fun. And her quote was, "Good, very professional, and kind." So for a doctor, I don't know what else you'd want to hear. And Rob Dorf went to medical school at the University of New England College of Osteopathic Medicine in Biddeford, Maine. He did his residency at St. Joseph Hospital and Medical Center, Mount Sinai Hospital, in family residency program in Paterson, New Jersey. He's board certified in family medicine. Now, his quote was a little more interesting. It said, "Does not, quote, greet and street you. I've never spent more time having an actual conversation with a doctor about my health issues. He seems to actually care." And he goes into great detail on any concern one may have. I highly recommend him. So I think we have two great doctors here who just are too busy to send me a little bio, which I don't blame them for. I'll give you all a chance to introduce yourself a little more fully and maybe talk about how immunology came to be something that you studied or work with. How does immunology fit into your life?
Thank you so much for the invitation. Actually, I get the extended health department here. We have all the nurses from the city of Nashua. So if I cannot answer, we have the communicable diseases program coordinator, led in Flavia Martin, and also our lead and asthma program coordinator, Patricia Gallister, and of course, Bobby Bagley, our City of Nashua Director of Division of Public Health Community Service, and Sasha Potska, our STD Program Coordinator. I started my career as a nurse way back in 1995. I graduated in the Philippines, but I came here 2005 and started my career as a health unit coordinator at Southern New Hampshire Medical Center, and eventually by 2007 I went to a long-term facility, and 2010 I was hired by the City of Nashua Health Department, and I really love the work because I can see that in the health department we are more on the prevention and control of diseases, and that's what I want for. In the Philippines, the vaccination or all the vaccines are very expensive, and we are lucky here in the state of New Hampshire because we are universal state, which means that even though you have some sort of insurance as a child, 0 to 18 years old, if you go to the health department and you don't have copay will still provide a vaccine. You have an access to get vaccinated, and that's a good thing because, as you know, there's a lot of diseases that has been eradicated by vaccination, and that's the 20th century.
Good evening. So I started my medical career, I graduated in 1987, so I have a little bit of perspective, of the historical perspective on this, and I immediately started working for the military, so I have some perspective on immunizing large numbers of adults and their children. And then 22 years ago came to the Nashua, Milford community. I practiced in Milford as a primary care physician in family medicine for 22 years there. And now I teach medical students here at Southern New Hampshire Health System. These are students from the University of New England, where Dr. Dorf graduated from. And also, I'm a substitute doctor in several of our clinics in the area. So you may have seen me in just about any of the foundation primary care offices. So I see adults, I see children. And I will say that I have seen, even in the 30 years that I've been practicing, the addition of several vaccinations that didn't even exist when I began. And I've seen the effect, the positive effect of having those vaccinations available. In the beginning of my career, we had always had some child on the inpatient ward who had suffered meningitis of various sorts, not just from meningococcus, but also from Haemophilus influenza, other organisms that we vaccinate against regularly at this time. We very regularly had adults and children admitted with periorbital cellulitis, which is an infection around the eye from some of the either Haemophilus or some of the other organisms that we vaccinate against. The incidence of ear infections, otitis media, we used to treat many ear infections. Now we treat ear infections, but fewer incidents of pneumonias and other diseases. So I have a little bit of historical perspective, and it's been very obvious to me that this has been a positive influence. Some of the other diseases that I didn't see because we were already immunizing against are now starting to be seen more because of a decrease in immunization in some areas of the country. So we just want to make sure that we can have an open discussion about some of this.
My name is Rob Dorf. I'm a family physician. I've been doing that for about 18 plus years. I've been in Nashua for about 15 of those. I am currently the medical director for Foundation Medical Partners, part of Southern New Hampshire Health System. And I still practice, although I practice in an internal medicine practice now. So I do a spectrum of obviously preventative management. I'm an osteopathic physician, which basically, from a philosophical standpoint, looks at people as a whole, not as a series of diseases or systems per se. So we try to look at people from a holistic perspective. So the idea of, from a neuromuscular standpoint, or even from an immunological standpoint, that generally the body's inherent ability to heal itself is remarkable, but if we have tools that we have available that can enhance its ability to do so, that those are processes that are natural extensions for what the body already does. As a physician, my role, as what I call a healthcare fiduciary, is to operate in the best interest of the people that I take care of. That means that I have to weigh the balances of good, benefits, the beneficence, benefits versus harm. So whenever you look at any decision point, particularly around vaccinations or anything else that we do, it's a very fine line, where you have to run, well, what's the evidence base of what we know today? I can't anticipate 20 years down the road what's the evidence base going to say, but based on good scientific rigor, what's the evidence base saying today is going to create the most benefit and minimize harm. Immunology is an amazing field. It's a complex system, and there's so many interlocking parts that have to work right in order to protect us, and from the various pathogens that we're exposed to every day, whether it's in your skin, or your respiratory tract, or anywhere else. Like it's a complex orchestra. So we have to take care of ourselves in order to maintain it. But there's things that we can do now that will enhance and protect us. In the 18 years that I've been in medicine, I've never seen measles before. And I've trained in some odd places. I've been out in rural areas. I've trained in inner city where we have large migrant populations, and you don't see a lot of that anymore. And there's a reason. It's unfortunate that we're seeing recurrences of some of these types of diseases that we haven't seen before, and the rhetoric and conversation around it has gotten kind of partisan around that. So hopefully we can have a conversation tonight that allows us to kind of look at the broader picture. Thanks.
Who wants to start? Anybody have a question for them?
I noticed that there's a lot of hepatitis out there, and there's immune shots for different types of hepatitis. Can you tell me how many different types of hepatitis there is? I know there's the B hepatitis, but I don't know the rest of them. Why you would need the immune shot for them? Because I know one of them is sexually transmitted. I don't know about the others.
I can start, and feel free to join in. So there are multiple types of hepatitis. The ones that we only have immunizations against 2 of those. One is hepatitis A, and that is a very valuable, effective immunization. And hepatitis A is foodborne. So if you travel, that is one way to get hepatitis A. If you're traveling somewhere where it's endemic in the population, if a person who has hepatitis A, for example, fixes your salad in a restaurant and you happen to eat that salad, you could easily get hepatitis A. Or it can be for example, in a school or in a community where it's just easily communicable from its hand washing is the most important thing with hepatitis A. So there does not need to be any sexual contact or blood contact for Hep A. And we really, really encourage you to get hepatitis A vaccination. It's a 2-part series, and it's 6 months apart. We always recommend it to travelers, but it's encouraged to anyone who would like to get the vaccine. And there's been an increase, and I think you can talk to that, Theresa. There's been an increase in hepatitis A, and I can go tell you about the rest of the hepatitis once she tells you about that.
For the state of New Hampshire, as of yesterday, because our directors here, Bobby Bagley, told me you need to give the latest. So the one that been reported as of yesterday, May 7, we have 98 cases of hepatitis A here in the whole New Hampshire. 5 of them within the greater New Hampshire region, and 3 of them is here in Nashua. And among those 98 cases, only 1 passed away. And it's not in Nashua, it's actually in other location, and that is someone who is also diagnosed with hepatitis C.
And so hepatitis is any inflammation of the liver. So you can get it. We call it hepatitis, even if it's from some organism other than hepatitis A, B, or C. If you have mononucleosis, or if you have some other infection that happens to go to the liver, we call it hepatitis. But we don't have immunizations against those. But Hep A we do, and that's foodborne, really important to remember. Hepatitis B and hepatitis C are the ones that are transmitted through sexual contact and any bleeding, any blood that goes from one person to another, and that can include bites. So if you get bitten by someone who had hepatitis B or hepatitis C, you can get that as well. So there is no immunization right now for hepatitis C. We hope there will be, but there is a 3-part series for hepatitis B. Every healthcare worker is required to be immunized against hepatitis B. I was immunized in 1987, and everyone who works in any sort of healthcare or as an EMT or a firefighter, anybody that could possibly be exposed to blood products absolutely gets that hepatitis B series. We now immunize all children, newborns start that hepatitis B series. And we encourage diabetics to have a hepatitis B series, and anyone with any liver issues at all, and anyone who cares to get a hepatitis B series because they think they might be at risk in any way. And that does not mean in any way that we are saying that that person is, having at-risk behavior. It is true that if someone is an IV drug abuser or has multiple sexual partners, they're more at risk for hepatitis B and hepatitis C, but it can be contracted in other ways, such as being exposed to blood products in any other way or by biting.
When you look at Hep B and Hep C in particular, the attack rate, meaning that the likelihood of transmission between hepatitis B and hepatitis C are very different. Hepatitis B is much more virulent, and so from an exposure standpoint, the likelihood of transmission is much higher within a relatively short exposure versus hepatitis C, which is more similar to HIV transmission rates. So if you get Hep B, we can, there's a vaccine for it, but I'm going to shove it in my mouth if I get any closer. So if you get Hep B, we don't have a treatment for it per se. We have treatment for Hep C, but no vaccine. So it's kind of a little bit of a paradox. Both of them can cause long-range complications. Hep C you can carry for years, not know it, transmit it, and then potentially later on when it reactivates, and I've seen this, you actually can, it can cause liver cancer and some other significant liver failure at some point. And then I've had patients pass away from complications related to that. Prior to the new treatments that are available to it, for Hep C treatment, there's only a couple of things that you could use interferon with ribavirin, but it took forever to treat and the fail rate was high, and also the toleration capacity for it was very low. And there's contraindications if you had depression and other types of illnesses that would complicate treatment. The new medications that are out are very expensive, but they're very effective for a portion of the population that actually can be treated. But if you have a version of Hep C that is not sensitive to it, then it's going to run a course that is inevitable, essentially.
Colleen, you mentioned diabetics. Any particular arrow that we should look out for?
This is a relatively recent recommendation as of the past few years. Diabetics tend to have a little more difficulty fighting infection of any sort. And so we try to protect our diabetics. We try to protect everyone, but we try to protect our diabetics specifically against anything that could cause infection. We have for a long time now made sure that all our diabetics get the Pneumovax, which is a vaccine against pneumococcus, an organism that can cause not only pneumonia, but sinusitis, ear infections, all sorts of other things. That people call it the pneumonia vaccine, which is a bit of a misnomer, but so we have been doing that for quite some time. And the addition of that, the recommendation for the hepatitis B series was just started a couple of years ago, and that's because it's just that much harder for diabetics to fight infection. 3-part series, highly recommended.
I am actually, here's a question for all three of you. I'm frankly puzzled at this issue around not getting vaccinated. Measles is the obvious example, but it strikes me that we have a fairly well-educated population, hopefully, in this country. What I'm confused about is that how could anybody go online, read something, and say, oh, I'm going to not get vaccinated because I read this thing. What does that say about our level of education on science, understanding of what immunology is about? Will we not get a polio vaccine now because somebody I mean, I just don't understand how this could transpire. Could you comment on why this is happening?
So I've spoken to many patients over the years. I mean, every once in a while there's someone who feels very, very strongly about this. And usually, many times these are very, very educated people who have done a lot of their own research. And their reasons are either first being afraid of possible side effects from the vaccines. For a long time, there was the misconception that there was an increase in autism from the measles, mumps, and rubella vaccine. That paper has since been debunked, but that still persists. There is also the phenomenon of sort of the forgotten diseases. So, yes, they are choosing not to give their children polio vaccines because there has been no polio. And so it's hard to explain to someone who's never seen any of this just how devastating it can be. I've tried to forge relationships over the years to build some trust. And with time, many people do start little by little to vaccinate. But I think those are the big issues: fear of side effects, fear of autism, which is being whether it's debatable whether the incidence of autism has gone up or whether we're identifying it more often. But there has been a good number. There have been many children diagnosed with autism, and it's a terrible thing to deal with. And I can't even imagine, how difficult it is for families with children with autism. So if they have any intimation that the vaccines are causing this, it's not that they're uneducated, it's that they are afraid, I believe, and also don't quite know what it was like not to have them. And to, walk around if you walk around any old graveyard, I hate to say it, you can read the gravestones. I've done this. And, you see the dates, and these kids are very young. But we're not exposed to that now. And so there's been herd immunity, which I think you all understand the concept of herd immunity. If you immunize a group, you're less likely to have disease of individuals in that group. So if we all immunize our kids, then the individuals that are not immunized in that group are less likely to contract a disease. So, do you have anything to add to that?
Do you have anything you want to add?
For me, I can see that because vaccine is a major breakthrough for the 20th century. You cannot even see polio nowadays. It was eradicated here in America, but in some other parts of the world, you can still see those cases, like I believe in Pakistan and some other parts that that they might have difficulty receiving vaccines. And as you could see, like I was just gonna say the hepatitis A, why are they coming back? And during 2013 to 2017, annually, New Hampshire is only getting 6 to 7 cases per year. And now it's ramped up to 98. And that is from January to May, actually it's, I believe, May 7, yes. So those are the questions that we might be thinking, how is this happening? Why are we still getting those? I believe, we can see that there's a lot of people travel all over the world, and those might be some carriers. And part of the thing that people might not be so worried because they don't see those vaccine anymore. And that's the good thing with public health. They're still there, and they continue to promote and prevent. And this is also part of public health because we're giving awareness to the community. It takes, like in the African saying, it's take a tribe to raise a child, and that it goes through with the herd community. I can just say that vaccination is very effective. Like the hepatitis A, it will give you 95% for the first single dose. And that is the best way to protect hepatitis A outbreak at this time. Of course, by washing your hands thoroughly because it's fecal oral route.
You know, we don't see a lot of the things, you know, I would say probably there's whole generations of Americans now that have never seen any of these diseases at all. Even she mentioned Haemophilus influenza used to cause significant problems beyond just a sore throat or a cough. It used to cause significant disease in children in particular. Also, like the other thing too is like, you know, the history of vaccine science it was imperfect to begin with, to be perfectly honest, you know, and there were some great successes, but there were also some rough starts in certain vaccines. We don't give oral polio anymore, even though it's effective. You know, there's a higher conversion rate where some, you know, children would actually contract polio. So that's why we use the inactivated polio vaccine. The DTaP, the tetanus, diphtheria, and pertussis, you know, had some complications with the pertussis component, so we use an acellular pertussis component, which helps dramatically reduce some of the classical side effects like fever, et cetera, that used to occur when we used to vaccinate children. Rotavirus, when it started off, you know, we ran into some unanticipated problems with intussusception, which is a bowel problem that can occur. We don't really totally understand the etiology of why that occurs, but the initial vaccine had some problems with withdrawn, re-engineered, and now it's available again. So, you know, it's a question of balancing, you know, need versus benefit. Again, like what I said, there are some populations, like premature infants, that benefit from the RSV vaccine, for example, because that could be significant problem in premature infants and even children developing that were premature at birth. But we don't widely vaccinate the whole population for that. So there's benefits and risks to everything. And again, the first step with regards to, you know, smallpox, you know, or anything like that, it was, you know, someone had to try something somewhere to see, you know, based on a hunch. The science and methodology around it now is far better understood. And again, the development process for these vaccines takes a very long time, but it's where you have a large enough population that the benefit of treating that person outweighs the risk of treating those populations. And like I said, like we have 40, 50, 60 years now of things we don't see anymore. For example, there's you know, shingles, for example. You know, hopefully that resonates with people in this room. Like, where does shingles come from? It comes from varicella zoster, which is the chickenpox virus, right? So how does it get in your body to begin with? You have to have chickenpox, and it goes dormant somewhere in a spinal nerve, somewhere between here to all the way down to the base of your back, and it sits there for years. And then once your immune system starts to falter a little bit, you know, because of a stress event, you know, failing immune system as you get older, you know, it's not perfect as you age, then it potentially reactivates. And that's what causes the virus to reactivate. It can cause inflammation, pain, and a lot of residual sequelae or leftover effects. So from that standpoint, you know, as you get older, per decade, as you get older, the likelihood of those residual effects causing significant morbidity, or, you know, where people leave the workforce early or have a quality of life reduction, or there's a suicide rate associated with that, and a whole bunch of other ripple effects that occur with that. You know, that's all because we used to throw each other, you know, if you had a kid in the neighborhood and you're like, oh, just go over to his house now and get chickenpox and get it over with, you know, because it went away. But at the same point, you've just basically inoculated yourself for life. So we have been vaccinating kids for chickenpox for how long now?
Since 1990.
Right. So we have generations of kids. You know, when we first started vaccinating against chickenpox, it was a single vaccine. But then we found that there were kids that were showing up with atypical presentations of chickenpox. They'd have like a single pox or some very vague symptoms. So they introduced a second shot, which basically was enough to rebooster the system so that created longer term immunity. So now you have generations of kids that don't have a dormant virus in their system. So the things that we have to do now for certain populations that we're recommending the Shingrix vaccine, you know, which is replacing the Varivax, you know, that almost eliminates that problem or starts to reduce the recurrences of that.
If I can, I'd like to sort of shift gears a little bit away from vaccines to another part of immunology. I can tell you that when I was in elementary school, we could have birthday parties and people, parents would bring anything in, and we didn't really worry about peanuts and this and that and anything in terms of allergies at that point. Or at least we didn't hear about it, but we didn't see anybody passing out on the floor either. Things that have happened over time is we're seeing things like antibacterial soap. We're seeing antibacterial this. Society, in a sense, is getting more sterile in terms of the products. Do you think, or has this ever been discussed amongst colleagues, that we are actually anti-immunizing ourselves, as opposed to go play in the dirt and pick up everything like a chickenpox party or something like that, or even just picking up any of the various immunogens out in public by using all these kind of products? And then do you think for me, there's a correlation between more of these type of products and seeing the rise or hearing about more incidents in terms of allergies and things like that, sometimes to the point of fatalities.
There is some talk that, there's about the antibacterial soaps causing, we do want to keep things free, surfaces free of bacteria and sterile when we're trying to keep a clean hospital, for example, or clean office or a clean kitchen. But you are correct that you can cause some resistance of some bacteria. And so there's a lot of talk about that conflict because we have two goals that don't necessarily align. And the other issue is allergies, which is an immunological response. And those conversations are being held as well. I will admit I'm not up to date on, whatever the latest and the greatest on that conversation is. I've just heard the conversation going on about whether exposure, keeping, not being exposed to certain allergens, and I'm not talking about bacteria in particular here, I'm talking about allergens. If you don't, are you less likely to be allergic to things if you grow up on a farm than if you don't? All that's kind of just being looked into. But on the issue of peanut allergies, for example, there was a big shift about 3 years ago. The recommendation had been don't introduce peanuts until, they're at least a couple years old, and then do it slowly because you don't know if they have an allergy. Now, unless there's a history of allergies in the family, it's the opposite recommendation, which is to introduce little bits early just for the reason you said, so that they won't develop an allergy. Because a recent study, which was I think 2 or 3 years ago, we started hearing about this, said just what you said, which is, if we're keeping them from all of this early on, they don't have a time to build an immunologic response to that. But that's specifically to peanuts, and it hasn't been extrapolated, as far as I know, but I'm not an immunologist, to anything else. But it's a good idea to think about and talk about.
Yeah, just the only thing I can add to that is that, to Colleen's point, the American Academy of Pediatrics, revisited their recommendations, because it's gone back and forth over the years about what's the potential impact for introducing certain food types that potentially pose allergy risks to infants and children, and when should you do that? I think the pendulum swung all the way over, so you're not introducing anything that's potentially a conflict, prior to 12 months, and so then the thinking had kind of shifted where you should start introducing these things early, depending on how the immune system develops, during early life. My son has a peanut allergy, so it's he's allergic to peanuts, but he's more allergic to other things. But it's not understood really, kind of where that really came from or why, And so food may be an issue. I don't know with regards to antimicrobial, soaps and things like that we use regularly. I don't want to pontificate and think about you can correlate anything per se, but it would be remiss for me to postulate on what theories might be, as to why that's occurring. It might be, because whenever you mess with the balance of flora, that's the things that we find on our skin, because there's a balance. You have bacteria, you have fungus on your skin. You also have your surface immune system, which basically coats your whole body and keeps all that stuff from getting in. And it generally does a good job. But once you start applying things that alter that balance, basically, that's where, like Colleen mentioned, like you alter the nature of those organisms and the resistance, but you also impact your body's ability to defend itself as well, because that layer of IgA antibodies and other types of other immune factors that are on your skin surface regularly, if we keep wiping them off, it compromises that barrier.
So I'd like to think that we understand what the scientific method is where we move gradually from one hypothesis to another, repeat it, repeat the findings, repeatability. Dr. Dorf mentioned that there are a lot of pseudoscience around. I think that with social media and the pseudoscience, we have to be very wary of correlation being mistaken for cause and effect. And I'll just leave you with the data about various towns where people counted storks, and the cities where more storks were seen, guess what? There were more babies born.
How do you make a decision on what to give people and what not to give people? Or what's a good vaccination and what isn't?
For the public health department, as a public health nurse, we always base that on our CDC website, Center for Disease Control, because they are the one who's the forebearer of what we need to give. And I believe that vaccines are really safe, because before you pass a vaccine, you're gonna go to you're gonna have an intensive, rigorous, they gonna test it, and we actually only got 14 vaccine preventable diseases, and for us, for the health department, if somebody goes there to get only those shots that required for school, which is actually only 5 vaccines. If we look at the recommended vaccines appropriate to the age of the patient, we look in the CDC, the updated, every year they post an updated, if they found some research, they updated it. Every year they have an updated version, and part of our health department is to make sure that we follow those standard guidelines by the Center for Disease Control.
In terms of immunizations, they do align. Some of the other recommendations don't always align, such as preventive testing, but that's another science talk, is which tests to do for screening. So sometimes there's conflict on timing of screening tests. But in terms of immunizations, the AAP, the American Academy of Pediatrics, and the American Academy of Family Medicine do align, and those are the recommendations that we follow. And we actually get an immunization schedule sent out to us annually, and we also get updates by email, and if there's something going on with an outbreak requiring or suggesting additional immunizations, we get emails from the New Hampshire, from the state as well.
There's a classification system looking at the strength of evidence, depending on, again, how a study was done, and the conclusions that come from that. Either you can get an A, B, C, D, or so the lower the letter, the poorer the studies, the evidence base behind it. And that basically, there's scientific councils basically for all those groups that compile all this data essentially review it, and then we'll issue a statement. Basically, that's not set in stone. It's basically, based on the current base of evidence as existing. The strength of evidence is A, B, or C with regards to what they would recommend. The U.S. Preventive Services Task Force does that regularly, and sometimes it's controversial. But it's based on the existing pool and the interpretation by a large body of reviewers. So we practice based on those parameters essentially that are set by large bodies of our colleagues, that look through the entire base of literature that's out there. And again, it's not set in stone. Things change. Recommendations change. Like even like aspirin, something that everybody said, "Oh, take aspirin." Then it was like, "Well, take aspirin only if you have this or that." Now it's like, "Well, aspirin doesn't do anything." So that's changed over 20 years. And so now I don't recommend aspirin anymore because it creates more harm than good. Your likelihood of, if you have no symptoms and you're asymptomatic, of potentially getting a stomach ulcer and dying from a GI bleed is higher than the risk of you potentially avoiding, it doesn't do anything for colon cancer. It doesn't reduce necessarily cardiovascular risk if you don't have cardiovascular disease. So those guidelines change, and as the evidence base evolves, and it's a constantly evolving thing. It's not like there's research that was done once and there's one conclusion and then it stops. It's always an evolving and changing field, and that's why it's dynamic, but that's why we keep making progress, because of the fact that there's always research going on to either prove or disprove existing tenets that we take as being, is it's just the base of what we expect it to be.
Okay, way in the back here.
Dr. Mawson out of Louisiana State University published 2 pilot studies comparing vaccinated to completely unvaccinated children in the last 18 months. Both of those studies showed that among unvaccinated children, autism and many other conditions were much lower. 3 to, in the case of allergic rhinitis, 15 times lower. Isn't it time to fund a large-scale vaccinated versus unvaccinated study?
I think the only problem with that is that you'd have to have a large number of unvaccinated children, and I would be morally opposed to that study because you would be placing a large number of children at risk.
On my way here, actually, I like to listen to Dr. Radio. It's from NYU Langone Medical Center, and it's all health professionals, doctors, and everything. And on my way here, a positive note, actually it is, they were talking about the flu vaccine in its 3rd phase of trial as protection against cardiovascular disease. So it was a brand new study, and the interventional cardiologist that was the guest of the show I was listening to had a guest, another doctor or researcher that was talking about the flu vaccine. People that got the flu vaccine may in the future, with the results of this research, have a lower incidence of cardiovascular disease. So I just wanted to talk about that because of lowering inflammation.
Yeah, that's right. Yeah, that's the only, I have not heard that,
No,
but
it's
if I were
brand-
going to make
brand
the
new,
correlation, I would say it would be because of decreasing inflammation,
Right.
because a lot of recent research is pointing towards inflammation as an underlying, contributing at least to cardiovascular disease, any type of inflammation. Even looking at dental inflammation
Right,
with
true.
chronic endodontic disease, et cetera. So that would be the only correlation I could see, but and I haven't heard that, but it's
Right, I
worth
guess it's all
looking
new,
at,
but
yeah.
I hadn't heard it either, but it may be promising in the future for all of us.
1979, I was diagnosed with hepatitis C. It took a couple of tries, but then every time I met with my health professional, I told them about it. In 1990, roughly, I had some tests done, and they said, no, you've never had hepatitis of any sort. So my question is, how do they know?
I mean, we can test for antibody to hepatitis A, B, and C. In fact, it's recommended to screen all of us in the baby boomer age group now for hepatitis C. When you were originally told, had no symptoms at all, so perhaps you made a blood donation?
No, I was weak, jaundiced,
Oh, you were
vomiting.
sick.
Yeah.
Okay. Did they say specifically that it was hepatitis C, or did they
Yes, they did,
call
because
it
I'd
non-A,
never heard of it
non-B?
before.
It
I
was the
didn't-
70s, because we used to call it
Nin-
non-A, non-B.
1979.
Yeah, I don't think they had identified hepatitis C at that time.
Perhaps. But I was wondering, how did they know 12 to 15 years later that I never had hepatitis?
So they tested you for hepatitis A. If you had had hepatitis A, you would have antibody to it, hepatitis A antibody. If you had hepatitis B, you would have hepatitis B surface antibody, as opposed to active hepatitis B. Like if you were sick right now with hepatitis B, we would test you for hepatitis B surface antigen and some other hepatitis B testing, but past disease would give you antibody, and hepatitis C antibody would tell you that you had hepatitis C in the past. Now, if what they might be testing now is for active, you can tell if someone's having active disease, active hepatitis C disease, and they might have tested you for that, and you might be down to a 0 count on that. But it's unclear whether you had hepatitis C.
Well, several times after that, I didn't tell them about it. And everybody came back and said, no, you've never had hepatitis of any kind. So I was just wondering if there was something left
Now,
behind.
you may have had, as I mentioned before, you may have had hepatitis where your liver was infected by a virus that was not measured for any other. A lot of other viruses can go to the liver and get you just as sick, but it doesn't happen to be hepatitis A, B, or C. So it sounds like you did have a hepatitis. It could have been from cytomegalovirus. It could have been from infectious mononucleosis or a number of other processes that can make you very sick in the liver. In fact, when people have mono, we regularly check their liver function test, and they can turn yellow and they can all those things. So maybe it wasn't hepatitis C, because I'm not sure they could measure hepatitis C at that time, but you may have had another form of hepatitis. That's all I can say, because if you had A, B, or C, we would measure that today in your blood with antibody.
I mostly just had a question if you guys had sources of information that you turn to that you think the public would benefit from, things that talk about science information and new studies in a way that's easy for the public to understand. And if you think there's any way that the public as a whole could kind of all get on the same page about this.
One website that we refer is the immunize.org. That is very helpful because it has some question and answer portion. And if you go to that website, it's per vaccine and what questions you are encountering that people might ask. And by reading those questions, you could definitely learn a lot from it. So it's very understandable. It's the language that they use is very good.
Another question here.
Is there a Lyme disease vaccine, and if not, will there be?
One came out many years ago, like around in the late 90s, but it wasn't terribly effective, and it was taken off the market. Or I don't know if it was taken off the market. We don't use it. We gave it for a brief period of time to people who are at high risk, such as landscapers, et cetera, people who are out there all the time. But right now there is no, as far as I know, no Lyme vaccine that is effective that we use. Oh, they're working on it.
But we also know that the types of organisms that cause a number of Lyme-like diseases are far more significant than just the those rickettsial viruses. So there's a number of pathogens that we actually have to look for that have overlapping symptoms. So a single vaccine would only deal with one, but it doesn't deal with Borrelia or Ehrlichia or Anaplasma or the other ones that can cause very similar symptoms that that vaccine wouldn't touch.
All right, well, why don't you join me in thanking our panel. And this was interesting because we heard some things that we should think about, like sample size matters. Like, go look at the data. Even the Wakefield studies, all out there. You can go study it. I have. So we should do our own homework and go look at the information ourselves and make our decisions based on what we think the science says. So thank you all for coming, and I appreciate seeing you maybe next month too.